Jen, and even though we don't have a vaccine for COVID-19, there's a number of things that we can do to protect ourselves from other types of infections. I wonder if you could just talk a little bit about vaccines and prevention from that perspective.
Big topic. Okay, let me try to sum this up in 2 minutes. I think general principles. I think it's very important that that we explore patients' vaccination history, and that wherever possible, that if vaccinations are needed, that we implement them before we start treatment. We can certainly give them with some medications after we start therapy, depending on the vaccine we're thinking about. Specifically with respect to tofacitinib, I think that the one that pops out as being relevant in this setting would be vaccination for shingles. And we've seen in some RCTs that the risk of developing shingles after starting tofacitinib seems to be elevated, maybe a little bit more magnitude than what's been seen with other biologics. And so we have some pretty good data to suggest or to recommend that patients that are age 50 or over should be vaccinated if possible by receiving the Shingrix or recombinant zoster vaccination before ideally starting the tofacitinib. And we even have some data, albeit less robust, that leads us to potentially recommend it when you're age 50 or less as well.
And Jen, there are both live and inactivated vaccines. Just to clarify for the audience, because shingles actually, the original was a live one, and now Shingrix comes out as inactivated. Just to give a sense of, the role of live versus non-live.
Yeah. So, I mean, I've universally shifted to using the newer non-live vaccination called Shingrix because it really is simpler. It's a simpler issue. The complicating factor for patients is that the non-live is a little more expensive, and they have to pay for out of pocket in many circumstances, not in all circumstances. Certainly younger patients often have to pay for that out of pocket. But it eliminates the concern about trying to administer the vaccination if you are a live vaccination, if you're receiving immunosuppressive therapy, because you either would have to come off the therapy and wait long enough until it was safe to resume the therapy if you took a live vaccination, or you would have to delay starting your therapy for your IBD if you received a live vaccination. So it really does complicate things a little bit, and wherever possible, I will use the Shingrix, which is the non-live vaccination.
The non-live has actually been shown to be much more effective at preventing shingles down the road. So, and it seems to last longer as well. So those are good reasons to use the non-live.
Sorry, if I can just say one other thing about vaccinations, which is something that I think is really, really important during the COVID-19 era, is for all of you patients, for all the patients out there, obviously who are listening, is please, 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 please get your flu vaccine this year. Every time I'm on a call with a patient I said, I can see that we can see it in Alberta if you've been vaccinated or not. I said, please go and get vaccinated for the flu vaccine, especially if we have a second peak and there's some overlap in symptoms. So protect yourself. And even we know that patients who get into problems, if they develop SARS-CoV-2, they can get secondary bacterial pneumonias. So, being vaccinated against pneumococcus or getting the pneumonia vaccine is also very, very important. So if you have the opportunity, please, please talk to your physicians about that.
And same for the parents of children. That's been a huge issue during the pandemic because of closures, that the routine immunizations are not being given to kids. And the last thing we need is an outbreak of measles or of chickenpox or through all of this. That's not what we want. So please, if your doctor is open, please get your child's regular vaccines as per the regular schedule as well.